All right, good morning, everyone. For the record, I'm Colette Peters, Director of the Department of Corrections, and while we are hosting this work group in a formal hearing room, I'm hoping that this will be a less formal event, and this work group will really engage in a rich conversation around the purpose of this task force, of this work group. So I thought we would start this morning with introductions and talk about our interest in the committee. I will tell you, this is an ongoing conversation that we've had at the Department of Corrections, talking about how to improve an already strong healthcare system inside the agency while looking for efficiencies. So we really welcome this opportunity to share with you the program that we have in place, and then listen to your expertise and ideas around where we may be able to take this already great program even further. I thought that I would turn to Senator Jackie Winters for opening comments, since she's the one that made this work group come to life.
Well, thank you. I'm State Senator Jackie Winters, and probably no stranger to the work in the Department of Corrections, nor am I a stranger to the work in the Oregon Health Authority. And having said that, as we look at systems and we look at changes that are occurring, and it's actually also no secret that I have an interest in what we will do in the future with the aging population. And looking at how can we actually not only improve on what we're currently doing, but do it in a way that is more efficient and actually less costly. I've been very fortunate to have a good co-chair in Representative Jennifer Williamson, and she joined me. And if you will note, the bill signers from the legislative side, I think it was every senator, with perhaps the exception of one who happened not to be present that particular day. And had Jennifer and I had a couple more days, you would have had every member of this legislative body, which says that it is an interest of legislators, and it is a bipartisan interest. It's not one that is one party or the other. And so I thought it's time for us to quit talking about, one, the collaborative relationship that needs to occur between the Oregon Health Authority and DOC, and that includes OYA and some of those components. And are there some things that we can do that will actually reduce costs? And I think we found during the session that we did have one piece of legislation that we passed through that helped, I think, about $13 million savings. So it was, and then of course the big one, as residents are staying in longer, they're sicker, and so the cost to DOC actually becomes greater. So those are your challenges. Those were my interests when I actually put the legislation together, and I did include in it, for obvious reasons, both community corrections as well as OYA. We can't talk about a healthcare delivery system in corrections without having all of those components. So that was my reason. Looking forward to good recommendations coming out of this body, and just know there's a huge interest among our legislative colleagues.
Thank you. Representative Williamson?
I think my good co-chair outlined succinctly our conversations over the entire session, where we talked a lot in our subcommittee about these issues. And so Senator Winters led the conversation about what we needed to do in the interim to get our arms around especially what we're going to do with the aging population. So I think I'm just excited to have more time and space to have this conversation than in the middle of a session.
Great, thank you. Representative Cameron, welcome.
Thank you. Sorry I'm late.
That's quite all right. We're actually just going through and introducing ourselves and talking about our interests in the committee, and I thought I would start with electeds first.
Oh, wow. We should be going last, I think, right? State Representative Kevin Cameron, represent South Salem, Almsville, Turner, and several of the correctional institutions for DOC and Hillcrest are in my district. My interest stems from just over the years being a part of reentry. We have over, well, it's down to 600 probably. It was up to 700 prisoners coming out of DOC on supervision here in Marion County. Worked hard to try to work with DOC and others to make that transition successful, reduce recidivism rate, and anything we can do to help people be successful. And I think their health while they're there and when they come out and in transition are real critical issues. And how do we work together, reduce expenses to collaborate? I think that's probably where my interest really lies as we move forward. So thanks for allowing me to be here.
Great.
And I thank the speaker for appointing me to this group too.
Great, thank you. Really appreciate you being here. Deputy DA Sparks.
Hi there, I'm Chuck Sparks. I'm with the Multnomah County District Attorney's Office. I'm really looking forward to this sort of other end of the process. I see the front end, and I don't have any particular expertise in healthcare, but I'm very interested in learning more. Thank you.
Thank you. Ms. Botkin.
Hi, I'm Mary Botkin, and I represent the folks who work inside the prison. This has been a long interest of mine with Senator Winters. We have talked extensively about ways to reduce costs, improve care, and get better outcomes with inmates. And one of my keen interests is the fact that we do have an aging inmate population, and increasingly we see more and more inmates with disabilities, and it's just a challenge about trying to figure out how you house them, manage them, move them, treat them, and pay for their health care costs, because we deal with a population that has not practiced a lifetime of good decision making and has not practiced a lifetime of healthy eating habits or living habits. So, you know, the health care costs that go along with that population are exorbitant and costly, and it eats away at the corrections budget, both for DOC and OIA, in a way that we have not been able to get sort of in front of and figure out how to pay for long term. And, you know, we have interest in spending money differently. So we have to save it before we can spend it differently.
Thank you. I will note that Dr. Norwood Knight Richardson was unable to join us today, as he is on vacation, I believe, but he looks forward to joining us next time. Celia Howes, we have with us by telephone today, so I'll next turn to you.
Thank you. Hello, everybody. I'm participating by phone today as I've got a 2-week-old baby at home right now, and so I'm hoping that I'll be able to more easily participate in person in the future.
Congratulations.
Thank you. I appreciate you all being patient with me on the phone. I'm a private bar attorney in Portland, Oregon, where I practice at a law firm named Hovett, Boyce & Olson, and we represent individuals who are facing criminal charges both in state and federal courts, and so we see a large population of our clients ending up in DOC facilities. And as you know, that we have an increasing onus on us as both defense attorneys and as prosecutors, I think, to advocate for sentences in the court system that are cost-effective, those sentences that are going to reduce recidivism rates, make our community safer, and also see good outcomes in the prison system. So I'm excited to participate in this conversation, and I look forward to see what comes of it.
Great, thank you so much, and we loved hearing the lungs in the background, so just keep that going. All right, I will next turn it over to Kelly Ballas, who has also agreed to sit as the vice chair for this work group.
Good morning. I am the Chief Financial Officer of the Oregon Health Authority, work for Dr. Goldberg. Been with the Health Authority for 2 years and have have had the opportunity to get deeply involved in a lot of healthcare reform work, and particularly with a focus on payment reform. My background is in the private sector, most recently with Kaiser Permanente. I also worked for other healthcare organizations in the state and the private sector. And I'm really actually very excited to be part of this work group. It aligns with so many of the other things that I do. I'm on the PEB board currently, the OMIP board of directors, and I'm on the finance committee for Cover Oregon. And this is just one more piece of healthcare reform and cost reductions that I'm fortunate to be able to be a part of.
Thank you. Very much appreciate you being here, especially with the background and expertise you bring to the table. Next, I'll turn it over to Director Paxarest.
Good morning, Fairbourse Paxarest, Director of Oregon Youth Authority. Pleasure to be on this work group. The situation with youth is different than adults. As Mary said, many of the adult inmates have, had not have good practices around healthcare, etc. Our hope is to help our youth not get there. Many of these youth who come to us lack basic oral and physical health elements, and a lot of our work is focused on prevention. And what we hope to do is by helping them establish good habits, prevent the further costs of the healthcare system in the future, in addition to helping them become crime-free and productive members of their communities.
Thank you. Great. Next, we'll turn it over to Sheriff Pat Garrett.
Good morning. Washington County Sheriff Pat Garrett. Certainly sheriffs and jail managers across the state are partners with DOC. We work with the same populations. We deliver very similar services. And we are equally challenged, face similar constraints in delivering health care to our incarcerated populations. Very important service, by the way, that we all provide. And like you, we share the pursuit of delivering the most efficient and effective healthcare services, and where we can find efficiencies, we're eager to be a part of that discussion. So I appreciate the invitation to be here today.
Thank you so much. All right, and last but not least, Mr. Miller.
My name is Carl Miller. I represent the people that work inside the penitentiary and at Mill Creek and at OSCI. Anyways, my interest in being learning the healthcare process is the budgetary side of it, and as naturally it's a competing resource for other issues that we need to take care of with the institutions, and I'm hoping that we'll come up with some ways to help improve both the safety for the staff and the clientele alike. So that's about it.
Thank you. Well, I appreciate everyone taking the time to share a little bit about their interests in the committee. I have to say that as the director of the Department of Corrections, it really is an honor to have people at this level who are taking this high of a degree of interest in this part of our program. When you talk about competing interests and the mentioning of community corrections by a handful of you, I think it's important to understand that we spend about the same amount on community corrections in the state of Oregon as we do medical care inside our prisons. So with that staggering thought, we do not have a printed agenda for you this morning, so I will next review what we intend to cover and then ask the committee if there's anything else you would like to cover before we end here this morning. Next on the agenda, Ms. Heidi Moad, who is our Senior Policy Advisor to our Governor, is going to talk about roles and responsibilities and what's inside this piece of legislation. We had hoped that the Department of Corrections General Counsel, Jeff Van Valkenburg, would be able to talk to us about the constitutional framework within which we have to work inside our medical program. He was unavailable for personal reasons, so I'm hoping he'll be able to appear before us next time. And then we will have our medical administrator, Bill Hafel, come forward and provide a health services 101 and really talk about how we're managing health care to date. And then we can review kind of the intent of the next steps and when we will meet before adjourning. Anything else of interest to the committee this morning? Okay, with that, I will invite Ms. Moad to come forward and talk about our roles and responsibilities.
Thank you, Madam Chair and Vice Chair and members of this work group. I'm Heidi Moad. As Ms. Peters said, I am Governor Kitzhaber's Public Safety Policy Advisor. I was tasked with putting this work group together, so very happy to see you all here today. Senate Bill 843 was the bill that created this work group, and you are required, under the direction of the governor, to recommend legislation to be introduced, hopefully, in the 2014 regular session of the Legislative Assembly to establish appropriate mechanisms to significantly lower the health care costs of the Department of Corrections. The bill goes on to list prioritizing legislative concepts that produce the greatest value for the department's healthcare expenditures, consolidate healthcare functions as appropriate, and may be integrated into other initiatives in the state to reduce healthcare costs. As some technical rules, a majority of the voting members of the work group constitutes a quorum. I believe, well, it's typical, although it doesn't say specifically in this bill, but typically the legislators are non-voting, right? Okay, so the majority of the voting members constitutes a quorum, and official action by the work group requires the approval of a majority of the voting members of the work group. This did require the governor to select a chair and vice chair, as you have figured out. We've already done that. Director Peters has agreed to be our chairperson, and the vice chair is Mr. Ballas from OHA. If for any reason one of you has to step down, we will make the appointment appropriately or ask the legislative leadership to make the appropriate appointments. If you feel the need to adopt rules necessary for the operation of the work group, you have the authority to do that as well. And finally, it is asking for the recommendations to be submitted by January 1st, 2014. So I kind of envisioned in my mind that this work group was going to be a fast and furious one, unlike some of the other ones that I have that are going to take place over the next several months and years. I think this will be a pretty quick turnaround. This statute says that you shall have access to nationally recognized experts and information from nationally recognized healthcare programs to aid in your deliberations. Should there be any of those people that you would like to see, please let us know, and we'll figure that out. Ms. Peters and I will work on that for you. And finally, there's rules in here about the compensation issues. If you have any questions about that, let me know, and I can review that with you. So that's it. A couple of things just moving forward. We chose to do this first meeting in a hearing room and do it under the public meeting laws. If you would like a less formal place to have the meeting the next time, we can discuss I can try and get the governor's conference room. I think we have the ability to record the meeting even in the governor's conference room. So depending on how formal or informal you want to make this, I'm certainly happy to make whatever work. Thanks.
Thank you. Any questions before she steps away?
Thank you.
Thanks, Ms. Moad.
I want to know where you got the cover for your iPad.
Where I get everything, Amazon.com.
And after that infomercial, we will have Mr. Bill Heifel come forward. And as he's coming forward, I do want to spend just a minute thanking him for all that he has done. As I listen to Ms. Moad read the bill and I hear lower costs of health care, you'll hear me say this multiple times. Our ability to actually lower the amount that we're spending on health care is unlikely, and often what you hear us say is we will mitigate the rise of the cost of health care, because as you know, inside prison walls or outside prison walls, those costs are going up. Mr. Haefel has announced his retirement after more than 35 years, of dedication to the department in many different capacities, now sitting as our healthcare administrator. And I just want to thank him for all that he's done to really shore up that program and put it out as one that other corrections agencies across the country look to provide health care to those adults in custody. He has also graciously agreed to spend the next 6 months with us following his retirement to help us with these efforts and others as we move forward. So with that, I will turn it over to Mr. Haefel.
Thank you. For the record, my name is Bill Haefel. I'm the Health Services Administrator for the Department of Corrections. I'm pleased to be here as a part of the work group to talk about what we're doing to mitigate the rising costs of correctional health care. As you can see from the slide, that's basically a breakdown organizationally of the number of physicians in each of the areas that fall under health services, medical, dental, behavioral health services, which is mental health, and pharmacy. We provide legally mandated medical, dental, mental health, and pharmacy services to the entire offender population. To accomplish this task efficiently, we use a managed care model, which is similar in some ways to a coordinated care model. We stress on-site primary care with early intervention and prevention. We use coordinated care and management of diseases, controlled access to specialists and specialty procedures, restricted pharmacy medication formulary, controlled utilization and utilization review and claims management. I'll go over each unit within health services, starting with medical. And please feel free to stop me with a question at any time if you have one. We recognize there have been questions about the rising cost of health care within DOC, so some of the things I'm going to talk about today will have to do with how we're mitigating these costs to the best of our ability, including our model as a managed care organization, use of a third-party administrator, and use of a restricted formulary, and a potential for Medicaid cost savings. Providing health care for more than 14,600 inmates, especially with an aging population, is challenging, but we take pride in what we do provide. Oregon statute mandates the Department of Corrections shall provide adequate food, clothing, health and medical care, sanitation, and security for persons confined. We're prepared to provide medically necessary care, which must be provided at a community standard. In health services, we see medical problems that are similar to anything you'd see in the community, ranging from minor to major problems, acute illnesses and injuries, to ongoing care for chronic disease, geriatric care, and end-of-life care. For the calendar year 2012, we had over 1 million medical encounters within the facilities. The vast majority of those, over 99%, took place on-site with our employees. We have 14 clinics, one in each of the institutions. Levels of care and coverage vary, and we operate infirmary level care in 5 of the institutions. So just a note, infirmary level care is not hospital care. It's pre and post-op, it's monitoring convalescents and patients that might require daily monitoring and skilled nursing intervention. We also have some specialty care on site. For example, we have a dialysis unit at Two Rivers in Umatilla, and currently have 20 inmates undergoing dialysis on site, where we bring the provider to the inmate to provide that service. We have a sophisticated population management program that places offenders in institutions to match their security risks, medical and mental health needs, and program and treatment needs. We bring in contractors for other specialty care to reduce the number of on-site medical trips, which impacts, of course, security's budget in terms of having to provide escorts for those trips. These include dialysis, ultrasound, cardiology, mammography, OBGYN, orthopedics, and sleep studies. We continue to pursue contracting with more on-site specialties as an alternative to transporting inmates off-site. We also are in the process of installing televideo equipment for a telemedicine telehealth in order to enhance our ability to utilize the resources in this growing field. We currently use this technology for mental health services, accessing resources from the metro area in rural areas where finding qualified help is difficult. Off-site specialty and hospital care is managed through the use of our third-party administrator, and this partnership allows for enhanced patient care, cost efficiencies, and care coordination. We utilize a discounted provider network, claims processing, comprehensive case management to reduce hospital bed days and improve clinical outcomes, as well as data management and reporting. We also operate a dental program within the confines of the prison system. We have on-site clinics at all but 2 locations, and those clinics are staffed by fully licensed dentists and qualified dental assistants. Inmates housed at facilities without dental clinics, we do have to transport to get that care when they need it. As for utilizing them off-site, that's on a case-by-case basis, uses the same model as medical does, where a panel of dentists get together, review the case to determine whether it can be handled on-site or needs to be referred off-site. Examples of most commonly performed procedures inside: treatment for serious oral pathology, extractions for infected or painful teeth, fillings for teeth with long-standing deep cavities, routine fillings, preventative cleanings, which is limited, and dental prostheses, which a copay applies. So inmates basically pay for, if they want to get dentures, they're paying for that. So for internal measures, we measure the off-site medical care rate of and a review of 0709, 911, and 1113 shows a flattening in that increase. So if you can look at the chart, oh, how about that? Notes don't apply. So we'll get to that. There's a chart that shows the cost increase. This chart shows some of the more serious health issues facing the inmate population. Hepatitis C, respiratory, and cardiovascular issues continue to rise among our population. Number of inmates with diabetes has increased 48%, while the number with HIV or AIDS has increased by 17%. The bar graph shows the degree to which we are seeing more and more inmates with severe conditions. Cardiovascular conditions have increased nearly 160% between 2006 and 2012. Respiratory conditions have increased 91%. In many ways, this mirrors what's seen in the community. A recent Washington Post article pointed out that a very small number of people account for a very large percentage of healthcare expenses. This next chart reflects the aging population. While the percentage of those younger than 30 is showing a steady decline, the over 45 population is growing rapidly. We've seen an increase of 34.5% in those 46 and older since 2006. This has a profound effect on the cost of health care. Not surprisingly, those 61 and older are our highest cost group, while those 18 to 24 are the least costly. We currently have 438 inmates over the age of 65 and 132 inmates who are in a wheelchair or otherwise immobile, 39 of which are over 65. Elderly inmates or inmates with significant medical
Mr.
issues.
Hazel?
Yes.
Can you say those numbers again slower?
Yes, I can. 438 inmates over the age of 65.
Over the age of 65.
Over the age of 65. 132 inmates in wheelchairs, 39 of which are over 65. So general research in the area shows that inmates are generally 10 years...
Bill, how many
Yes, ma'am.
currently do you have on hospice?
I don't know the answer to that. It's relatively few. Typically, we have 3 or 4, maybe as many as a half dozen system-wide. If you'd like the exact number, we can get it for you.
But most people don't know that you've got
The hospice program.
program.
So generally speaking, research within the correctional population, because of the kind of lifestyle which was referred to earlier, the kind of lifestyle that they've led, they are 10 years older physiologically than their chronological age. Here's the chart with my missed note. So if you look back at 05-07 and a $29 million cost for off-site care, between 05-07 and 07-09, that jumped $13 million. And at the time, the third-party administrator we had reported to us that we should expect, based on the length of sentence and the kind of population we're dealing with, that we should anticipate a 20% per year increase in the cost of off-site care over the next 5 years. And we said that's just not doable. So for beginning in the beginning of the 07-09 biennium, we had gone out and gotten a new third-party administrator. We went from 29 to 42 million. Actually, they started in July of 9, because this is the last 2-year window we have with them before we go out for another request. So as you can see, we went from 29 to 42, we went from 42 to 46, and 46 to 49. So the rate is flattening. And this is, again, to be clear, this is off-site care only.
Mr. Habel, can you talk a little bit more in depth around how that third-party administrator helped us do that?
Yes. We had talked about the number of encounters previously. There were 6,416 off-site encounters in 2012 compared to over 1 million on-site encounters. Those 6,416 off-site encounters cost $22,312,534. For comparison, Health and Human Services, the average American spent $700 on health care in 2010. In that same period, we spent $560 per inmate per month. We made a decision. The current contractor's average rate of reimbursement is between 70 and 80% with specialty providers and hospitals. There is a significant difference between rural and metro areas, though, in terms of discount. DOC, we made a decision to purchase enhanced services from a third-party administrator, or TPA. Included in those services are a provider network coverage and off-site care case management. Overall costs have leveled off as a result of those discounts in case management. The rate of savings has significantly improved, and inappropriate overnight and bed days are now denied. Why is it flattening? The volume of catastrophic offenders and their costs have ramped up more slowly than last year. We're working to get offenders out of the hospital as quickly as we can. If when appropriate, for example, if they're staying in a hospital because there's a particular piece of equipment they might need, but we don't have it, but we can get it, we arrange to get that even if we just rent it for a brief period of time to bring them back to our care. Frankly, some of it is luck. In 2012, we had a lower rate of hospitalization than we had before. I can tell you that at the end of the last biennium, things were looking really good, and the last 6 weeks, we were hammered. We had some really catastrophic cases go out to the hospital, some of whom were in the hospital for over 30 days.
And if I might, for those of you that are responsible for the Department of Corrections budget, as we're managing to that end-of-the-year spending, it is medical services that we look to for that luck, if you will, as we're trying to end the biennium on a positive note. And when these cases happened at the end of the biennium, we really were anxious that we might not end on a positive note.
Can I ask a question, Mr. Hutt?
Yes.
Can you talk a little bit, or maybe you have it later on in your presentation, about drug costs?
Yeah, about formulary medications. Yeah, it's later in the presentation.
Thank you.
The other thing we've done is implement an evidence...
Question, Bill.
Yes.
Is the data segregated out to, when you talked about that, the length of stay in 30 and, is it segregated out that which is intense medical issues versus those issues that could be there because of what's going on inside the institution? I think you've got two different kinds of populations. You've got the population that occurs because, let's say, it's cardiovascular or something like that, and then you've got the violent population that could create an environment or something that happens that...
For example, you mean like somebody being...
Like somebody beat somebody else up, or
Right.
somebody
Yeah.
stabs somebody, or... Because that's a...
Yes, we do track that.
Okay.
I don't have that broken down for this presentation, but if it's something that you'd like, we can dig that up for you.
I think, Madam Chair, may I?
Yes.
I think it would be helpful to sort of understand what is institutional in creation and what is lifestyle in creation, you know, I mean, what,
Well, I'll get you the numbers if you wish, but I can tell you that the vast majority of off-site care is their health, not via soul. Vast majority.
But it isn't a nuance.
But it is a nuance.
That we
It does
have to
drive-
manage
It does
too,
drive
that-
cost.
so do we have,
Go ahead, Ms. Botkin.
do we have in place a way to monitor intake of food products that will make them healthier? Do we have an ability, you know, I have this unique perspective on this because, you know, I hear all the stories on the street from our members working in the institution, and one of their biggest frustrations is that we actively treat diabetes, but we allow the inmates to continue to buy sugar, lots of sugar. And their frustration of giving people insulin or diabetic care and then allowing them to consume vast amounts of white sugar, which aggravates diabetes and makes it worse. I don't know where the lines are from their constitutional right to have whatever they want that's available and our ability to control that diet so that it is not exacerbated.
I'll take this one for you, Mr. Hazel.
Thank you.
So I hope that the nutrition aspect of healthcare can be part of this conversation. One of the things that we have been charged with over the last decade is driving down our cost of food and food delivery. And I think that that has impacted the health of those in our care and custody. We, as you know, many of you know, we're going through an organizational transformation and trying to move the whole agency into an outcome-based organization, and it's going to include some ability to measure the health of these individuals when they arrive and when they leave. Because we don't have electronic health records, it's hard for us to quantify that right now, which, as a side note, I'm hoping that's part of this conversation as well. So some of it, Ms. Bodkin, is their right to access, and some of it is, quite frankly, our need to manage prisons. And food is part of that. Now, I will share with you that it's something that we struggle with. As I walked death row a few months ago, I noticed that more than half of them were obese, and as we looked further, more than half of those had type 2 diabetes. And so their lack of access to exercise, their access to canteen, clearly is contributing to that because they didn't have type 2 diabetes when they arrived. And so it is something that we're interested in talking about. I know that a few years back we did eliminate soda for this very reason. We were giving soda instead of milk because it was less expensive. So this is something that we're talking about internally and hope to talk about externally as well. Anything you'd like to add, Mr. Hazel?
Just that what happens inside actually mirrors what happens outside. There is an obesity epidemic in this country, and a lot of it is tied to people's nutrition. So, not to minimize at all, but I agree with you, but just that our population mirrors society.
And one of the cost-saving measures that we've engaged in over the last couple of years is really expanding our gardening programs so that they're not only creating and growing fresh vegetables, but harvesting them and consuming them as well. So we are trying to make steps in that direction, but certainly there's room for improvement.
Going to open the door to talk about electronic records, and I wrote a little note down here whether or not there's the interface between the county jails and the courts and what have you, so that the individual coming in, that you have captured their medical profiles and their needs when they arrive.
Senator, just to be very clear, we do not have an electronic health record system.
You're wishing for one.
But the one we're wishing for will interface as you described.
And eventually, part of the whole interconnectivity piece is that all systems are gonna have to be able to talk to one another, to be able to share information.
So that includes OYA and, because they also have individuals who actually graduates to the, unfortunately, to DOC. I need to put that one in there on the side, because we work very hard during session. But it is important, to know that there is the interface and that you're able to actually talk to each other. From all the various court systems and your jails, and that was another reason for including the jails as well as, and I haven't heard it yet, and I'm sure it's coming up, the mental health issues.
Yeah, there's no doubt that an electronic health record system would prove for efficiencies inside our organization, but there's also no doubt that there's duplication going on at the county level and tests being redone when they arrive at the Department of Corrections, so.
If you have an inmate come to you who has previously been a part of the healthcare system, do you receive those records, or are you unable to access those?
We get them, but they're paper.
So obviously an electronic system, the Northwest Permanente is
Right.
completely electronic, so do you have any way to get those, or do they have to reduce those to paper and then?
Yeah, we don't have a way to take information electronically at this time.
And Mr. Haefel, would we get it from we would get it from the county?
Yes.
Correct.
So as inmates are transferred to the department, either their records are shipped with them, or they come shortly thereafter.
And can you talk about what shortly thereafter means? Because I know that there's been some frustration that shortly thereafter is long after they leave intake.
Yes, it does happen. Technically, the records come, most of the time the records come with the inmate when they get delivered to intake, and so we have that paper information when they get. We also do an immediate, as they're sitting and receiving a discharge, we do an assessment of them. A nurse comes in to see them, walks through, kind of, do you have any medical issues, any mental health issues, just to get a sense of them right from the start, before they get a full physical and workup in the first 30 days that they're at intake.
But to be very clear to Mr. Sparks' question, the information that you receive is only what happened while they were in custody at the county level. It's not that we're
Right.
scooping back to their general practitioner if they had one over the years,
Right.
correct?
And I can tell you that most inmates did not have health coverage before they came to us. And again, because we can't collect information electronically, we've done some surveying at intake in 30-day windows to see what we had. Roughly 30% had coverage, and the vast majority of that was government-sponsored. It was either VA, Medicaid, or Medicare.
Is that percentage expected to grow as we grow the Oregon Health Plan?
One would hope.
Has anyone looked at that?
We have, and it is our hope. When you look at the information across the country, they're estimating that 99.9% of the adults in custody will be eligible in those states that are engaging in Medicaid expansion. And so this is something we'll talk about in brief here in a minute, but it is something that's not being, it's just now being talked about at the national level. It's not something that's been a focus as Medicaid expansion has rolled out. And in my thinking, there's so much to be done on the front end for those individuals that will be eligible. I mean, imagine if they had alcohol and drug treatment, mental health treatment on the front end prior to probation or while on probation, and then certainly upon reentry back into the community.
Or if even before they get into the criminal justice
That's
system
right.
would be helpful.
Right.
Yes, Mr. Vice Chair?
And so it sounds like you may have already identified the electronic health record that you think will be appropriate for correction.
So we're looking at systems right now. We're
Okay.
actually hiring a project manager
Okay.
to guide us through that. We've looked at a number of products, one being the Epic system.
Right.
But we also, because we're not like a federally qualified health facility, we don't utilize ICD-9 coding or ICD-10 coding internally for what we do. So we're looking for more corrections-specific type of, because we're kind of a unique animal in the healthcare world. But I know that we've looked at, we've looked at Epic system that Multnomah County is using, which has actually been kind of targeted. They've modified a little bit for a correctional environment. We're looking to see if the two add-ons they have, which is dental and pharmacy, will be seamless integration. Because frankly, if our folks have to go to multiple screens and systems to try to get access, that kind of defeats the purpose of being efficient. So, but we're considering multiple systems at this point. We have not arrived at one yet. Thank you.
As you look at systems and, given that you actually have off-site, as well as on-site, as well as systems that are, I'm looking at hospital systems now, all currently, if I look at even here in our community, when they went online with the doctor's offices, were they compatible? So, I mean, that whole issue of systems being able to talk to each other, and particularly since you've got both on-site and off-site and in various locations around the state.
Well, and that's the whole piece is one of the advantages of the Epic system is that's mostly what the hospitals are using is Epic. So the integration there should be seamless. But the requirement for other systems is they're all going to have to be able to talk to each other. So that is part of what we're looking at is we need to be able to communicate externally.
And for the record, for all members of the committee to be aware, thank you to the legislature who did approve a bit of funding for us to engage in this exploration this last biennium.
So one of the other things we've done to try to mitigate costs, there's a second piece to this, and that is the patient themselves. And so we've implemented an evidence-based chronic disease self-management program. It's a Stanford-validated program, and we're working to fully implement it across disciplinary management model for high-risk patients in an effort to holistically manage their care. We recently trained more than 80 inmates to lead chronic disease self-management workshops in 7 of the 9 institutions. So partnering adults in custody with staff to deliver this curriculum conforms to the Stanford Patient Education Center's expectations for program delivery. So we're doing it by fidelity. We're doing it as they designed it and expect it to be carried out. No other system of incarceration in the country is doing both a staff and inmate-led CDSMP workshop and evaluating the program. By the end of 2013, all institutions will provide staff and inmate-led CDSMP workshops for persons living with chronic disease. Electronic health records. So, challenges for medical services is a lack of an electronic health record, and I think we've talked about that pretty substantially here. Shortage of infirmary beds for men on the west side of the state. The only facility that has beds on this side of the state is the Oregon State Penitentiary, where the infirmary is on the 3rd floor. Anybody see a problem with that? If the elevator power goes out and we have an emergency and have to get someone downstairs, we're either wheeling them down the stairs or carrying them on a stretcher down the stairs. That would be 3 flights. So the way we currently operate is when one inmate moves from an institution to another, we ship that sometimes very large paper health record with them. And that can be challenging given that we have 14 locations and over 14,600 inmates that we move around the system. To that end, we're working to lease a system designed for corrections that includes the capability to integrate with other healthcare systems. It won't automatically provide connectivity to the outside, but it's an important first step. So we're in the kind of the research phase at this point in trying to determine which system fits all the needs that we have. I talked about the infirmary level care in the 5 institutions. The majority of those beds are located east of the Cascades. There are 40 beds for men on the west side and 23 beds, which is not private room. It is a dorm setting with 3 private rooms for high security inmates. There's greater access to specialty providers and hospital care in the Salem-Portland metro area, where unfortunately we have the fewest infirmary beds. This means we struggle to find room on the west side, to find beds for patients recovering from surgery, who are discharged from the hospital, who have a chronic illness. And conversely, we have more infirmary beds on the east side of the state in rural areas where medical resources are more distant or difficult to find. We also see an increase in some of the more serious health issues facing inmate population, including chronic illness. Our biggest challenge right now is recruitment of physicians and nurse practitioners, both on the medical and mental health sides. Right now, for example, we have between EOCI, Eastern Oregon Correctional Institution, and Two Rivers Correctional Institution, Pendleton and Umatilla, about 45 minutes apart. We have 3 physicians positions and 3 nurse practitioner positions. We currently have 1 of each filled. So our medical director, our infectious disease doctor, and 1 of the physicians from 1 of our institutions goes out there 1 week a month to see patients to make sure that we keep up with their care. We are actively recruiting. We've hired a headhunter to find people for us. Yes, sir.
Do you use any physician extenders in terms of physician assistants or nurse practitioners?
We use nurse
or
practitioners.
Or these new categories of community health workers and all?
That would be great. But the classification system that we have right now, we'd begun a class comp study, I think it was in 2007, that was specifically healthcare, started and stopped multiple times, eventually stopped. So we're limited by the classifications that are available to us and in the comp plan at this point. We would love to be in a different place.
Is your other area of issue you're talking about the rural communities and being able to recruit someone who wants to
Yes, yep.
not live in the metropolitan or in the valley? And
Correct. That has been the difficulty. Even the headhunter who we've had actively engaged finding people, we may have a line on 2 physician's assistants who might be willing to go to Umatilla, Pendleton. We have yet to find a physician, and it's been months. We're also seeing inmates in our system with more medically complex issues. For example, earlier this year, we had an offender come into the system with a very rare condition who requires medication that costs about $47,000 a month. Without that medication, she will die. So there's no ifs, ands, or buts.
so, Bill,
Mr. Hazel,
I'm retired, I'll answer to either.
it's very weird to be on this side of the DS.
Understood.
How did she manage her disease before she got here?
Well, I'm not entirely certain. I know she was taking medication for it.
but who was paying for it?
Who is, yeah, I mean,
I don't know.
mean, you know, I guess there's a question about, you know, obviously I don't know what the disease is. $47K a month is a lot.
And the drug is produced by one manufacturer, and you order it off their website, and you pay whatever they say.
I think that's a valid question.
I
Agreed.
mean, how did she treat it before?
Well, somehow she was covered somehow, and I don't know whether it was the Oregon Health Plan or whether it was private insurance, but upon incarceration, they're no longer eligible for coverage.
That raises an important point. To follow up, you said 30% of your inmate population upon intake had some form of health care. Most of them government supplied, but let's say, just for argument, that a third, 10%, had some sort of private health care coverage. Is there any mechanism for, let's say I'm in prison and my domestic partner or spouse is employed and has health care coverage that would extend to me? Is there any way for the DOC to invoke that plan and have that provider pay even a part?
So we've looked at that, and in most cases, most insurance plans have a provision that terminates coverage upon incarceration.
Now, I realize that this may be a somewhat controversial suggestion, but is there a legal mechanism to say, as a cost of doing business in the state, as a regulated industry, that the insurance company can't do that? And you may or may not be.
the person to ask that question.
That would be a question for the insurance commission. I can't answer that for you.
Madam Chair, if I may, the Oregon State Sheriff's Association worked as hard as we could to get legislation passed that would prohibit private insurance carriers from discontinuing coverage when someone is incarcerated. However, we were not successful. So we're looking for more partners and to make another run at that.
When was that?
Last session.
Last session?
Yes, ma'am. But that's an excellent point.
Thank you, Sheriff.
And I can tell you that Medicaid, they're determined, they're ineligible upon incarceration. And the only exception to that, we'll get to here in a minute.
That's that beautiful bill that we passed last session.
Yes.
Representative Cameron?
Not that I plan to visit your establishment. Does PEB have the same rule?
I honestly don't know, Representative Cameron. I can find out.
Be a good question.
I'm sure they do.
We don't know.
Don't know.
It's a great question. We'll follow up.
I don't want to find out the hard way.
I can tell you, most insurance companies have a clause that terminates coverage upon incarceration.
Including PEB?
Including PEB.
I don't know PEB.
Okay.
ROF?
Probably, or we'd know.
But
People would be covered,
yeah,
Right.
I mean,
I would assume.
yeah.
Okay.
Thank you. So now we're to Medicaid. So I want to start with, we talked about ineligibility. So inmates are not eligible while incarcerated. And there's one narrow window of exception, and that is they are considered to not be incarcerated when they are in a hospital or a nursing home for more than 24 hours. And that is in a 1997 letter from CMS. And we wanted to take advantage of that. And with the coming of the changes with the Affordable Care Act and the change in the reimbursement rate, we actually looked at this a few years ago in cooperation with the Oregon Health Authority. And at that time, it looked like we were going to lose our discounted network. They were going to drop us, which means about half our business is hospital, the other half is specialty providers. And so it looked like it was about a wash, and so to avoid disrupting the entire network, we decided not to move at that point. With the coming of the Affordable Care Act, however, right now the reimbursement rate of what Medicaid pays is 62.7%. Effective January 1 of 2014, it's 100% of what Medicaid would cover. So we made a business decision to go for January 1 of 2014. And we are headed down that path in conjunction with the Oregon Health Authority. So our intent will be to pursue Medicaid reimbursement for inpatient hospital stays for more than 24 hours for all patients who are eligible. And the possible cost avoidance to the department is estimated at $12.5 million. However, that's based on three factors. All inmates cooperate, hospitalization costs remain about the same as they did last biennium, and that the billings are about the same as they were last biennium. Those are all a little iffy.
And I would also add, we estimated beginning July 1.
Right.
And we've planned not to
No,
begin.
we actually did January 1
We did,
of 2014.
okay.
That was based on the last 18 months. And that 100% level reimbursement is good through 2016, and I think it's through 2020, it gradually reduces to 90%, at which point that's where it's scheduled to stop, so.
So at the risk of pushing the envelope, wouldn't we be better off hospitalizing somebody like this $47,000 a month inmate? Because certainly the security costs of supervision would not outweigh the $47,000 a month in hospital care that Medicaid would pay 62% of now and 100% of in January, starting in January.
She does not require hospitalization, and they're not a housing facility, so they wouldn't take her absent the need for hospitalization.
Although I will tell you, Ms. Bodkin, as we were talking about our budget reductions strategy this last week, our budget administrator recommended the same thing.
Which is why he's not in this role. Sorry. Yes.
Maybe you should be.
Well, because you mentioned both hospitals and nursing homes, and I don't know what exploration, and of course, the good Ms. Botkin and I have kind of chewed over the years of how we can, what we can do with the geriatric population and still get Medicaid dollars, and and whether or not you will continue to look at that, because if Medicaid will pay for nursing homes, and I just think we've just got to come up with a better mousetrap of figuring out how we're going to do it.
They just cannot be run by the Department of
I
Corrections.
know,
Yeah.
I know.
That-
But you know, we do, we actually do third-party management in other arenas, and so, you know, I'm just looking and thinking outside the box of,
No, I'm with you. I'm not saying we can't do it. I'm just saying it can't be run by the Department of Corrections, or they'll be determined to be ineligible.
So what that would mean, and we've talked about this before, Senator, is redefining what in custody means, in these specific cases.
Well, and I think it's really important for us, as you look at all the changes that the legislature has done and wants to do with the department, that we also look at who are the risk factors. An aging, dying inmate is not a risk to anybody. A disabled inmate is not going to run away. And if they try, it's not going to be hard to catch them. Okay? You know, I mean, I just think that we need to figure out if there's a way to move people to an alternative environment that may be secure, but doesn't have the DOC label on it. You know, I mean, you know, God rest her soul, my mother-in-law had Alzheimer's of the worst kind. She was an exit seeker, which meant that she was always leaving and not knowing where she was going to go. We ended up putting her in a facility that resembled a minimum security facility for her final years, because we could not let her get away from the facility. There's no reason why an inmate who couldn't be in the same environment, and Medicare and Medicaid paid for a good portion of her care.
So, Mr. Hafel, I'll take this one away from you as well. How's that?
That's fine.
No doubt, and this is something that we have looked at. You know that the statute does allow for medical and conditional releases for certain offenders for this very reason. The parameters around the crime that these individuals committed is very tight. And it excludes most Measure 11, it excludes most sex crimes. And if you'll remember that graph that showed the fastest growing population are those 65 and older, because that's the population where the high cost medical care individuals rest. Thank you, Christy. Is those individuals who are staying with us longer, for the most part, are coming to us as with sex crimes, because their length of stay is so much longer. Those are the individuals that fill up that red costly category. And when you talk about people aging out of crimes, you age out of stealing cars, you age out of breaking into houses, you don't age out of sex crimes. And so when you look at the statistics around recidivism of sex offenders, they are very low. But the reason they're low is because of incarceration, is because of supervision in the community. And so I always say, if we just looked at the statistics there, Mary, as the director of the Department of Corrections, we should be releasing those individuals. As the mother of 3 little girls, I have an entirely different opinion.
So we're also working, the department's transition and release unit, as well as health services staff in conjunction with Oregon Health Authority staff, are working towards ensuring all eligible inmates are enrolled prior to release, beginning in January 2014. We'll continue to work with the Oregon Health Authority staff to learn more about Medicaid. and how the Patient Protection and Affordable Care Act will impact healthcare for adults in custody.
And Mr. Havel, can you, for the group education, talk about what it looks like today? Because today, individuals are leaving our care and custody without the safety net of resources on the way out.
The only ones currently, there was, I think it was Senate Bill 913 that required some level of a plan for folks who are mentally ill, who are being released into the community. We actually have 2 folks that their sole purpose, that's what they do, to connect resources for both the mentally ill and the medically fragile people who can't basically take care of themselves when they release, to find resources for them on the way out. To some extent, there is some work done around Medicaid, but it's a really small amount right now. With the expansion coming in January, the intent is to enroll everyone who's qualified. And as the director referred to earlier, they believe that about 99+% of the paroling inmates will be eligible for the expansion of Medicaid.
And so on the ground, the reality is, without this expansion, today individuals leave our care and custody, and it can be quite some time before they're able to enroll again in Medicaid, up to 30, 60, 90 days without access to medications and health care.
And we made a decision, I don't even remember how many years ago, it's since I've been in this job. We used to release inmates without medication, and we ended up determining that that was probably not a good thing to do, and so we now release everybody with a 30-day supply of medications. There's been some question about, well, could you give them 60 or 90? Potentially, but we weren't funded for the 30. We did that because we believed it was the right thing to do, and our physicians are no longer their care provider once they parole, and so if there's any kind of problem with the medication beyond 30 days, frankly, our doctors get a little nervous about being held responsible when they're no longer really their physician.
And that's a lot of medication to send somebody out the door with.
Yes, because yes, it is, and some people are on multiple medications.
But that was better than sending them out the door with nothing.
Agreed.
Madam Chair,
Yes, Director.
has there been any study done on cost benefit of this new practice? 30 days of medication?
In terms of recidivism reduction and other outcomes like that?
Yes, and not necessarily recidivism, but naturally, I mean, everything being connected, there is an impact. We think this is the right thing to do, but has there been any follow-up to see if that actually has been, is there any way to determine payoff?
I don't know. Kind of once they leave our care, we don't have a way to track them.
What about community corrections?
But could we through community corrections?
Yeah.
It's a great question. We
It's a
should
good
pose
question.
it with
Yep.
our
Yep.
research staff.
Yep.
Okay. Thank you. We will do that.
And if it's not connected with community corrections, it should be connected to community corrections. Because as we look at, seamless systems and to be able to intervene early, and as we look at reentry and the avoidance of individuals getting back, I think that connection is.
I mean, we do connect with community corrections in terms of when they're releasing and if they're going to be taking medications. Because if the inmate, as happens with humans, we make mistakes, and sometimes they leave without those medications. We have a form we have the inmates fill out prior to their departure. In the event that happens, we send their medications to their parole officer. So there is a connection. We have not tracked whether it makes a difference.
So what we will do in terms of follow-up is we'll ask our research staff if we can measure the benefits of sending these individuals into the community. But if not, and the if not is probably because we didn't establish a baseline before we changed the program,
Right.
can we and should we begin to measure the positive outcomes following the Medicaid expansion? Okay. Yes, Ms. Botkin.
Can I make sure I understand? So and I should understand this, and I don't, I'm sorry. So when an inmate leaves our custody and we do their release planning, we make sure that they're signed up for Medicare, Medicaid. And do we, no, we don't.
We don't, except for those individuals that fell into Senate Bill 913, those who had high mental health need, we can't. They are not allowed to sign up for Medicaid or Medicare until they are no longer an incarcerated individual. And so their access to that federal funding is actually terminated upon entering the Department of Corrections, and they cannot submit the paperwork until they are no longer in our care and custody.
So, is there a way to rectify that? I mean, we do other things to help the inmate transition for a successful release. It's in all of our best interest not to keep supervising the same people. Is there a way for us to assist inmates in getting their applications for Medicare and Medicaid in place once they're released, and to make sure that they transition from health care, from our treating physicians, to the Oregon Health Authority once they're released?
So the short answer is, under current law, no. But that's a great segue into what Mr. Hafel is just about to talk about. Because of the Medicaid expansion, that's exactly what we now can do. And that's why I think the impact that we're going to see around the Medicaid expansion with those involved in the criminal justice system is dramatic. And as Mr. Hafel pointed out, especially those who have yet to get involved in the criminal justice system.
But this House Bill 2087 comes online, the first of the year?
Yes.
So that, what you're talking about, and the relationship with the Oregon Health Authority,
Can and will, and the planning is in place, and this is what Mr. Hafel's going to talk about now.
So our intent and what we've been working towards is not just to apply for those who will meet that narrow exception for Medicaid while incarcerated, but to prepare applications in collaboration with the Oregon Health Authority so that upon release, we can't apply early. We can fill out the application. They won't be determined eligible till they walk out the door. But the day they walk out the door, we can hit the send button and send that application, at which point we've been told basically determination is almost instantaneous. So potentially they'd be covered when they walk out the door.
Yeah.
That's what we're hoping for. That's what we're working towards. Now, unfortunately, inmates have a constitutional right to health care within the prison system. They do not once they leave the prison system. And they're returning, in some cases, to poor communities where they no longer get treatment for their problems. And the task of meeting those health care needs upon release can be tricky. So while they may have coverage, it doesn't guarantee access.
Right.
But that would be where the Oregon Health Authority and the coordinated care organizations and the navigators would come in. And that's another reason why, when I did the legislation, that, it was so important to have both the Oregon Health Authority and DOC to have these conversations, because they have the responsibility for coordinated care in our local communities, and they have the responsibility for these navigators and what have you. So I do think we need to talk about how we can actually blend.
Everything.
Sure, Mr. Vice Chair.
Yes, we should be able to get, first of all, there's the individuals eligible have a choice about which coordinated care organization they would like to enroll in. Without a choice, we will automatically enroll them in a coordinated care organization as soon as they are determined medically eligible for Oregon Health Authority.
And it could very well be, the planning that's done with the inmate as they prepare to return back into the community, that becomes a part of the packet of understanding that medical piece and coordinated care.
Right.
I don't know, I'm just thinking out loud.
And the objective would be have no gaps in coverage.
No gaps in coverage.
No gaps.
What is the projection around availability and if they will be afforded access to care when they return to their community?
I'm confident that if they are actually enrolled, and not 100% will be enrolled in coordinated care organizations for a variety of reasons. Some have choice. If they're Native, for example, or dual eligible with Medicare and Medicaid, they can choose not to be enrolled in a coordinated care organization. But any individual who's enrolled in a coordinated care organization should get immediately assigned to primary care in a patient-centered primary care home. And I would say that I have a very high level of confidence that that will happen around the state. If they're not in a coordinated care organization, then access is very difficult. It's a challenge.
And now we move on to mental health. As you can see from the slide here, it talks about we provide services to mentally ill inmates in 8 institutions: Snake River, Eastern Oregon Correctional Institution, Two Rivers, Deer Ridge, Coffee Creek, the Penitentiary, OSCI, Oregon State Correctional Institution, and Columbia River. The largest numbers of mentally ill inmates are housed at Snake River in Ontario, while the most seriously mentally ill are housed at the Penitentiary. More than 50% of the inmate population has some mental health need. While keeping them safe and other inmates safe, our staff safe, our philosophy around providing mental health treatment is to provide treatment and coping skills. The saying is, nobody goes to prison to get well, not if you have a mental illness. The single biggest thing that when I represented Director Williams, when the state hospital began doing their planning, one of the things the consultants talked about is the single biggest thing you can do to reduce anxiety in a mentally ill population is give them space. Well, they're not going to get that in a correctional environment. It's very close quarters, living environments are very tight, there is really nowhere to get away from folks. It is kind of a health engagement model. Our goal is to motivate the offenders to engage in learning about their mental illness, their cognitive abilities and skills, so they can learn to self-manage their symptoms, recognize their symptoms, so they're able to kind of help manage that on release.
And this is important, and this is something that has occurred under Mr. Hazel's leadership, because it really is, I want to stress it, because it really is something that we think is helping us bridge their health care in the community, and this isn't always how we manage this population,
So the behavioral health staff provide mental health assessment and evaluation, case management and treatment plan formation, medication management, suicide prevention, individual and group treatment, mental health risk assessment and management plans, release planning, crisis response and prevention plans, response to victim of sexual assault, and other services to mentally ill and developmentally disabled in those 8 institutions. We work with the inmates to help them understand their mental health diagnosis and offer opportunities for them to learn practical skills to help them manage their medication, symptoms, and activities of daily living, as well as how to communicate well with their providers. Care is prioritized to inmates who have severe and persistent mental illness and other high-risk factors. We use a tiered housing system for the mentally ill, or a continuum of housing based on acuity. At the top of that is the mental health infirmary, which is basically 40 beds, and it's a crisis stabilization unit. It's for people that are having a psychotic break. It's for people who might be hearing voices, and it provides short-term psychiatric crisis stabilization, evaluation, maybe even medication adjustment for seriously mentally ill inmates. The other unit we have is a behavioral health unit, and that's for inmates who have a serious mental illness who've engaged in violent behavior. That means they've engaged in a violent assault that caused bodily harm to another person, either an inmate or staff, and rather than just isolating them, which tends to exacerbate symptoms, we put them in this unit and they actually get treatment in that unit. But safety is still paramount for staff and the inmates as well. Then we have an intermediate care housing unit. That's about 70 beds. I'm not sure quite how to describe this unit because, as they say, water finds its own level. And so this is kind of a transition unit for inmates who are coming out of the behavioral health unit and maybe going back to some other living condition or living environment. Inmates who've been stabilized in the mental health infirmary who are on their way out and need a period of adjustment coming out of that environment to make sure they're okay before we send them out to live somewhere else. And sometimes we just have folks that we know are so mentally ill, they're just going to go in and out of crisis periodically, and they're never going to be able to live out in some kind of a general population setting, and this is where they end up residing.
What percentage of them have comorbidity, that alcohol and drugs is the other component?
I don't have that number for you, but we could get it.
Mr. Haefel, you gave the percentage of the inmates who have mental health issues. I didn't catch that. What was that?
50%.
50%, okay.
What's the gender breakdown in that number, men versus women?
We'll actually get to that if that's all right.
The comorbidity issue, I think, is important as we talk about treatment plans and what have you,
Right.
making your way through, and I suspect that it's relatively high. If it's mirrors the rest of the population.
Right, I would agree. And one thing that came to mind as you were talking was really you talked mostly about those with fairly serious mental health issues. And, one of the elements of coordinated care organizations is actually making, in the primary care setting, the behaviorists available, mental health professionals available in that same setting to the extent that that's possible in a co-located, within all the limitations that we know you have to deal with. So I'm interested in that at some point, talking more about that.
Okay.
And when you say 50%, are you talking about, now my recollection is that the 50% number includes personality disorders as well as Axis I diagnosis. Am I correct in still assuming that that's what you're doing? Or is 50% Axis I diagnosis?
It's not Access One, no.
Okay.
It's, and I'll actually get to what some of the diagnoses, what illnesses those contain.
Okay.
From the intermediate care housing, we have basically a day treatment unit in several locations designed for inmates with severe and persistent mental illness and moderate to high acuity. And these inmates require daily to weekly contact with a provider. We also then have mental health housing units, which both day treatment and mental health housing units are considered general population. It happens out in the facility. It's just a housing unit that's designated to house the mentally ill. Mental health housing is designed for a vulnerable population of inmates with mental illness and or a developmental disability. So if I could, the day treatment unit, there's 132 beds department-wide. There are 528 beds for mental health housing. Based on changes, how we manage the mentally ill, we've seen some positive outcomes, and I think it's too simplistic to attribute it to any one factor. I think it's the way the department has chosen to manage inmates, the way we communicate with inmates, an emphasis on inmate offenders being accountable for their actions, trying to reconnect them with their families, to provide incentives. Along with this component, I think that the way we're managing the mentally ill has helped reduce the number of cell extractions and the number of uses of force, as well as contributed to the, frankly, historic level of vacancies and segregation beds.
That says a lot for the caliber and training and the ability of the staff, with inside the prison environment, that you're having those kinds of successes, because they could not occur if those who are on the line weren't actually implementing the changes in policy. So when you're talking about a 50% population, and you're also talking about a different type of need as far as staffing need in the institution, in the various institutions.
And it's not just mental health staff. It's a
that's my point.
Yeah, absolutely. The security staff are bought in.
That's my
point. The providers
point.
are bought in. It is a treatment team.
Thank you for those comments, Senator. I really appreciate it, and I think you're right. I think as we look at an all-time low in the use of seg beds and the reduction in assaults on staff. It really is contributed to that final piece that Mr. Hafer was talking about, that the mental health staff and the security staff are working in a very symbiotic way to manage this very difficult population.
I don't think that the general population understands that the profile and the difference that are in our institutions, and that's including OIA and others, that it requires a different kind of security and teamwork than it did 20, 30 years ago. And as you talked about, and I just needed to put that on record because there is a difference. And it requires that our staff, that her security staff, were doing a job of keeping the lid, not only lid on, but helping to actually treat and work with the individuals so that there's an optimum of success on the way out.
Thank you. So, there's a lot of focus around self-harm, suicide attempts and suicide. While quite frankly, if a person is committed to doing themselves in, they are going to find a way to do it. And all we can do is our best. We'd have to have eyes on a person 24/7, 365, and that's just not possible. But we do everything in our power to make sure that does not happen. I can tell you that both for security staff, for mental health staff, for the medical staff, a successful suicide is a very impactful, very hard thing to deal with. People begin asking themselves, was there something else I could have done? What did I miss? What didn't I do? And sometimes there just isn't anything. You can do everything absolutely right and still get a bad outcome. Suicide attempts and completed suicides have decreased. Suicide attempts have gone down by 13%. There were 138 attempts in 2011 and 120 attempts in 2012. Completed suicides have gone down, and again, 3 in 2011, 1 in 2012. We use a system of case management to coordinate mental health care and treatment. Inmates are assigned a qualified mental health provider who functions as a case manager. Appointments are scheduled at intervals based on the severity of their diagnosis and their symptoms. Treatment plans are developed for individuals with severe and persistent mental illness, and support plans are developed for developmentally disabled inmates with a mental illness and a lower acuity. The system of assessment and reassessment is continuous and provided to all inmates on a caseload or those who may need services at some other time. We provide brief solution-oriented therapy. We utilize cognitive behavioral therapy and dialectical behavior therapy skills and training techniques to teach symptom management to the inmates. We teach them emotion regulation, tolerating distress, interpersonal relationship skills, and mindfulness skills, which help check their impulsive thoughts and behavior, which, as you can probably imagine, can be a problem in a prison. Staffing. We have qualified mental health professionals, psychiatrists and psychiatric nurse practitioners, and an RN transition specialist that we referred to earlier that helps those that are mentally fragile gain benefits to be covered and taken care of when they release. We also have a management and support staff team in each institution where services are provided, and some central administration for oversight and to kind of set policy. There is one chief psychiatrist, a clinical director, and an administrator. They provide initial intake assessments for inmates coming in through the system, through Coffee Creek, and individual and group treatment in each institution. We also contract with psychiatric nurse practitioners and psychiatrists for those areas where we have difficulty recruiting staff. We actually use televideo to provide services in those areas. There are gender differences when it comes to mental health, and while 47% of the male population has some mental health needs, it's much higher for the female population. It's a total of 78%. So, the highest need for treatment are inmates with a designation of the highest need qualify as SMI, seriously mentally ill. It's a legal definition defined in statute. These inmates have diagnoses such as schizophrenia, psychosis, recurrent major depression, or inmates who have had a serious suicide attempt, engage in serious self-harm behavior, with problems in perception of reality, or have cognitive functioning problems related to dementia or Alzheimer's. SMI inmates may be seen daily, weekly, to every 30 days as routine when their symptoms are active, and medication management for this population may be an integral part of treatment. Severe mental health problems, and those are the mental health, the MH3 inmates listed at the top. What I'm going to describe next, severe mental health problems, are the MH2 line there, and that is inmates with a severe mental health problem, those diagnosed with symptom acuity that require regular and ongoing case management and treatment. Inmates with these diagnoses are scheduled for case management and appointments based on their level of functioning and symptom acuity. They are met with every 30, 60, 90, or 120 days, or more often if they're in crisis. Crisis prevention and crisis response is ongoing. Medication management is regularly reassessed. Some diagnoses common to this designation are PTSD, borderline personality disorder, delusional disorder, or dissociative disorder. Highest need for treatment. Inmates with a designation of highest need for treatment qualify, sorry, that page reprinted. Providing services to the mentally ill in prison with a physical space and environmental factors and limitations are not conducive to positive change and present special challenges within a prison environment. Mentally ill and developmentally disabled inmates are at increased risk of victimization by other inmates. They often have more difficulty following rules and get into trouble more frequently than their peers. The difficulty in recruiting qualified mental health professionals in rural areas presents another challenge to service delivery. I should add, throughout the course of any offender's incarceration, he or she may develop mental health symptoms and be placed on a caseload simply because of the environment. Being incarcerated in and of itself can be a traumatic event, and prisons were not designed to become a large provider of mental health services. In addition, as with medical services, new PREA standards will require training, implementation, follow-up, and increased service delivery needs. Specialized training has been created for certain classifications, and all staff and contractors will need to attend this training.
Okay, Bill, you just opened a door that I want to keep open for a minute. PREA.
Sorry, Prison Rape Elimination Act, for anybody who didn't know.
Having just returned from a tour of the Eastern Front on all three shifts, crowding. I don't know how in the world we can hold staff accountable for PREA enforcement when they can't see what's going on in the corners of their housing units. You know, the line of sight has diminished immensely since we opened the facilities over in Eastern Oregon. I haven't been to the west side yet. It's still on my to-do list. I am increasingly concerned about some of the environments in which the staff is working and in their ability to make sure that the inmates are safe and themselves as well.
Right. Happy to. So the prison, for those of you that aren't familiar with the act, the Prison Rape Elimination Act was passed by Congress in 2003, and 10 short years later, standards have been approved. We are to come into compliance with that federal legislation and those standards in 2014. The department has said very early on that the prison, the intent behind that congressional act was safer prisons. So it's something we're a proponent of. There's no doubt, Ms. Bodkin, that because of budget reductions, we now are utilizing temporary and emergency beds at a very high rate. We have worked very diligently to minimize that. House Bill 3194 over the next 6 years is going to help us peel back some of those temporary and emergency beds, and we won't return to these rates until for another 6 years. But we will return according to the current projections. So while it remains a concern, it's something that we're trying to push forward for compliance, because it doesn't mean just safer environments for those adults in custody, but also for our staff. And I'm happy to spend some time offline, since the question doesn't relate to medical, but spend some time offline on some of the work we're doing around PREA and PREA compliance as well.
It has a subsequent consequence for medical and potentially.
Yeah.
It does.
And I think also part of that, when we get in line of sight and some of the other issues, and some of the facilities are actually constructed during times, I think of particularly our great big one that's there, but that's a whole nother discussion, because it gets us into capital construction and some of the other issues.
But I would be remiss if I did not bring it forward as a concern on the part of staff that they don't know exactly how they're supposed to keep inmates safe from each other.
Ms. Bodkin, anytime you want to talk about financial restrictions in front of the very people that send my budget my way, you are more than welcome, so thank you.
She's able to do that quite often.
Yes, and we appreciate the partnership.
Thanks, and I'm happy to stay out
By
of that
job.
conversation. So, one other thing I'd like to mention, through a memorandum of understanding with the Association of Oregon Community Mental Health Programs and the Oregon Association of Community Corrections Directors, DOC carries out a pre-qualification process for public benefits for inmates with serious mental illness. They also ensure that inmates with mental health needs released from DOC custody with a 30-day supply of medication, and participate in interactive planning with the community mental health care providers in the county's release. The partners have agreed to sign an updated MOU every biennium after the legislature passes its budget, and to meet annually to problem solve and share best practices. We have a total of 847 designated mental health beds in the Department of Corrections. Now we move on to pharmacy and medical stores.
And as a point of order, I will note that you have about 7 more minutes, because we'll need about 10 minutes to prepare next steps. And I'm promising people the gavel will drop at noon.
Okay. Well, let's see, I'll condense this. So we use kind of a managed care model within the department, and one of those where we talk about a coordinated care organization, really we are, because we literally have a captive audience. We utilize we do have one electronic piece, and that's a prescription ordering system, a pharmacy system. So the providers do a direct provider entry into the system to order medications. That is reviewed by pharmacists. It automatically pops up if there's a contraindicated medication, because we have dentists, physicians, and psychiatrists potentially all ordering for the same patient. And this is one way to ensure that we don't give somebody something they shouldn't get. We use a centralized, basically a mail order pharmacy. We centralized that for efficiencies. We actually did a comparison several years ago against a large private provider of pharmaceuticals. They beat us on labor costs. We beat them on medication costs. And in the end, we were actually a little bit cheaper than they were. So we're always looking for comparative comparators. So obviously the medication rooms and the pharmacies are licensed and inspected on a regular basis. We use centralized purchasing and a controlled inventory to promote efficiency and manage our costs. We use a restricted medication formulary that's established and monitored by a multidisciplinary team of physicians and pharmacists. They review on a monthly basis the list of approved medications. It's not that you can't get something that's not in formulary, but you got to go through a process to get it. And if it's in need of medication, you can get it. I would like to tell you we use 92%. So I just read an article in the Oregonian that was within the last week that about 84% of prescriptions filled in the real world, as we like to refer to it, are generic. The Department of Corrections in the last year, 92% of the prescriptions we filled were done with using generics. But I would also tell you that 8% slice that are branded drugs are significant, cost more than that 92% of generics.
Are most of those mental health drugs?
No. Some of them are mental health drugs, but drugs to treat HIV, hepatitis C.
Well, that would be the ones that I carved out, HIV and mental health and those, yes.
Hepatitis C, drugs used to treat hemophilia, specialty drugs like the one I referred to earlier, $47,000 a month. There are no generic substitutes for those. And we use generics 100% of the time when they're available.
There was a question, and I'll ask it for the Oregon Health Authority, because it was the question as to whether or not bulk purchasing could be done by the Oregon Health Authority through Tom Burns's, and whether or not it would be more cost-effective if the department utilized that. And I understand that, are you still purchasing through a multi-state system?
We are still purchasing. So the Minnesota Multi-State Contracting Alliance for Pharmaceuticals is a nonprofit, government entity-only group purchasing organization. The group that OPDP goes through is Premier, which is a for-profit group purchasing organization. We've done multiple studies. There was a budget note which we responded to. One step in that was to complete a full review about availability and pricing in non-pharmaceuticals that DOC could purchase as well. At this time, Premier does not have all the drugs we use on contract. Now, we've been told they can get them on contract, and that they could get contracted pricing for non-pharmaceutical, so medical supplies and equipment, which we're also able to purchase at a discount through MCAP. So we were told that they could get them under contract. However, until the contracts are in place, it's not possible to do really a meaningful price comparison. So we use the nonprofit GPO that's government agencies. Its 40 members are 46 states and the cities of Los Angeles and Chicago.
And I would just add to that while we weren't able to do an exact, meaningful comparator, the estimated projected savings was fairly minimal compared to what we spend, and we worried that we would negatively impact some of our county partners who are purchasing from MCAP currently. So.
Is it something that we could take another look at it? The only reason I say that is because as Senator Winters suggested, Tom Burns does have the belief somehow that we could save some money in pharmacy. Is it worth revisiting?
I think we reviewed it in pretty large detail with legislative oversight in the review. If there's something that we missed in the comparator, we could revisit it, but I'm not familiar with anything that we missed.
I think if I can recall some of the other, it said it was hard to get from apples to apples.
Yeah.
Also, if I remember the report that came back as a result of the budget note, and I know Tom feels very strongly that it's there, and I question where you have 47 states and major counties and what have you, and that purchasing, that volume capacity to purchase, as to whether or not, those of us in the state could actually compete and drive down a lower cost. And I think that that's also true with OYA. They too are not a part of the state drug purchasing system, and here again we get into the apples to apples and what have you, as well as they've been able to actually come up with some price points that are less than what Tom is doing.
Okay. Well, for myself, I personally would like to understand it better, so maybe at some point we could sit down together and talk about it.
Perfect.
Challenges for pharmacy and medical stores. Cost of pharmaceuticals, new drug therapies, hepatitis C. Recently, boceprevir and telaprevir were approved. There's another round of hepatitis C drugs coming that are under review by the feds right now, and they're likely going to be approved, and they have less side effects but are more expensive. So We're doing our best to manage that. We originally estimated that the number of hepatitis C patients we have would probably cost us about $6.4 million over the course of the biennium. As it turned out, it was just over $2. One of the drugs is much more expensive than the other, and the less expensive of the two new drugs has more side effects. And so where we were able to utilize that drug and the patient was able to tolerate, we used that one. When they weren't able to tolerate or their disease was more advanced, we used the more expensive drug.
And that type of analysis saved quite a bit of money. We anticipated a much higher cost, assuming that we would have to use that new drug for all the patients in that. So again, I appreciate the analyses.
And then sometimes just the availability of medications for anybody that, well, I don't know why you do it for fun, but might be forced to pay attention to the pharmaceutical marketplace. It is an endlessly fascinating world. I might be so bold as to say it, at times manipulated. I mean,
like most things in our world.
The largest purchaser of medications in the country, which is Medicare, via legislation, not permitted to negotiate prices.
Yeah.
So, so the new standards have become or new treatments and therapies have become a standard of care, both in pharmacy and without. We talk about medical inflation. There's really two different drivers at work here. One is cost to treat, which is the treatment may change. For example, what might used to be treated with a medication is now a surgical intervention, and then a new treatment, a new drug like hepatitis C, or where inflation is really just this pill cost this much last year and it costs this much this year, or this medical device. The recent article that I referred to earlier about the cost of healthcare across the United States, according to the World Health Organization, they did a worldwide comparison of healthcare costs. The United States has the most expensive healthcare in the world and not the best outcomes. Any other questions?
No, but you might want to explain briefly, because we often get that question from constituents, and that is the issue of standard care based on community care, and there are those who think that perhaps you shouldn't do one procedure or the other because that seems to be a little excessive, and I know court cases say that you have to provide.
Yes. So I can address a little of that, and that was actually what we'd hoped that Jeff Van Valkenburg would be here to kind of frame that.
Oh, we're going to do that next week. We're fine.
But what I can give you, Senator, briefly is we're required to provide, the court cases are we're required to provide medically necessary care, and the care we provide is at a community standard. And the definition we got from DOJ around what that community standard looks like is the community standard of health care is generally interpreted as what a group of physicians recognizes as the accepted treatment for a patient with similar medical problems with full ability to pay.
So it's the full ability.
So, I'm an advocate for good health care for inmates because I think it keeps the prison safer. But I also believe that the community standard of care should look like the Oregon Health Plan. That is not necessarily what all the doctors think they want to provide, but what the citizens actually have available. And that, this sort of makes me a knuckle dragger in some ways, because I really do believe that our community standard of care should be measured by what the majority of Oregonians can expect to get if they cannot afford to pay for Cadillac insurance or even Datsun insurance. If they, it is to me what most citizens would have available to them. And That's a Von Valkenburg question, not a Hayford question.
And he'll be able to answer that. It really is a legal determination.
Yeah.
I was going to say to Ms. Moad, I think Ms. Botkin is asking for an appointment to the bench. But you can talk to her about that after the meeting.
I think I lack the one thing that is critical for an appointment to the bench.
But thank you. Yes.
Okay.
Mr. Sparks.
You seem to be reading your remarks, they seem to be prepared. You're very well prepared and covered a lot of ground. I've got the PowerPoint slides, but do you have conveniently available an electronic version of your notes?
Yes.
Could we get those? Great.
If I might follow up too, thank you, Madam Chair. I would love the slides too electronically. There's just some text here I'm having trouble reading. And up to you how you want to do this. I think I have some data requests. You know, we've got cost of healthcare exploding, which we all recognize. We have some aging factors, you know, with respect to our population. That's an important factor. On your slide 5, for example, your medical services with that aging population as you move left to right. I'd be really curious as to medical costs per day per inmate by age group. You know, to kind of peel that layer back one more. And then a similar request for your slides above and below that. I could email that to you, Madam Chair, if you'd like that. Thank you.
Thank you, sir.
And the other data tease is because the population, the mental health population, at 50%, and I think tease out those costs that are related to mental health. I mean, when we're talking now, 50% of the population has some at one level of mental illness. If I ask the same question at community corrections as to what their universe looks there, the sheriffs and what have you, because they've had this ongoing discussion of the appropriate use of their jails for the mentally ill and what have you. So I think it's a subject matter that you know that needs to be elevated a bit as to what our inmate population looks like, both at the county level as well as at DOC level. That's a large population, so then you're talking about a whole different set of resources.
Okay, we can follow up with that information as well. Any other data points that you're wanting to review for the next meeting?
I actually would like to see breakdown by inpatient hospital days, cost, utilization, mental health, but various categories of outpatient services in more detail, if you could make that available.
So help me again, you said mental health.
Well, I said inpatient medical
Oh, okay.
hospitalization, inpatient mental health hospitalization costs.
Inpatient or outpatient? Meaning?
Both separate categories of inpatient care. If somebody's admitted for medical care or surgical care, that would be another category. Inpatient mental health, and, you know, if that's available. On various outpatient categories of care.
So there's
lab tests, you know, imaging costs, that sort of a breakdown.
Okay.
Whatever is easy to get to.
Okay.
You know.
For that care that occurs outside of our prison walls.
I'm talking about the
we
external
call
care.
outpatient.
Okay.
Right. I think that's where we were tripping up. So you want a more detailed spending on what we spend outside of our prison walls.
I would like to see that,
Yep.
mostly for comparison purposes, and we can talk more about it, so we can do this with one run instead of kind of back and forth.
Okay.
Okay.
Question
Yes.
I'd like to ask is, there was some talk about moving people outside into outpatient care so that they're eligible for Medicaid. What's the tipping point at that, as far as having those people out there and the savings we're going to have in medical costs, as far as the increased costs we're going to have for supervision?
It's hard to frame a response to that because it's dependent on numbers. I mean, it's a hypothetical situation at this point.
But what I would say is that the medical determination to send someone to a hospital isn't going to change. So because we now have access to Medicaid, I don't see this, Mr. Miller, as us increasing the number of individuals that will be going out to the hospital. It just means we'll be replacing some federal dollars with some general fund dollars with federal dollars.
Yeah, there was some talk about, like, with the medication being $49,000 a month.
Oh,
Or if you move that person into outpatient care, you would still have to have supervision.
so I think what they're talking about is, the potential of exploring a new facility. You're absolutely right. And either we would have to redefine what the statutory language definition consists of around what is in custody, or we would have to simply create a new world, internal to DOC where we had a geriatric facility. I know Senator Winters has talked about what if we used OSPM for that sort of, housing. The reason we couldn't go down that path is because in order to collect Medicare or Medicaid, it can't be a facility run by the Department of Corrections. So all exploratory, but it didn't appear that we had anything that was viable during those analyses. Thank you. Okay, and so, not seeing any other questions for next week, in addition to the follow-up that was just mentioned a couple of minutes ago, I've noted some other follow-up questions and answers. So the agenda will include just a recap and data sharing. And then we plan on having Jeff Van Valkenburg talk to us about the constitutional framework within which we must operate. Any other agenda items for next time, Representative Cameron?
When is next time?
I haven't gotten there yet.
Okay,
That's a great question.
thank you.
Any other agenda items? Okay, not seeing any. Let's talk about next time and frequency of meetings.
Would you, it could be not next time, but the timeout. And that is what other states are doing, if there's any data or things out there. And, we talked about California on this geriatrics. We're not the only one that is facing this issue of the increase in geriatric population and its impact on budgets. And so the question is, some research on what other states are doing to solve this particular problem would be helpful.
The National Conference on State Legislatures has done some work on this. I don't know how much, but I know they have resources. They've looked at this.
And, Mr. Haple, I was actually going to ask you, since the bill says that we will have access to national experts, is there anyone that you think should appear before this work group?
Think about it.
Newton Kendig is actually the head of the Federal Bureau of Prisons and is really highly respected in the field.
Okay.
Whether we could get him or not, I don't know.
I think that would be helpful.
Okay, we will explore that. And then, if anything else comes to mind, send an email to me and we'll manage preparing. We have a pretty tight deadline. January 1st is when we need to come up with proposals, but I also know how busy everyone's schedule is. So, any thoughts around frequency of meeting between now and January?
Frequent.
In 2 weeks? In 3 weeks?
I think we do like.
The sooner the better.
I
We want to get something in
think we
February.
want to get something done, and when we did 3194, we had frequent meetings.
We did.
And I think in order to get the background information and begin to really drill in, I think that they need to be frequent.
When we run into having it.
We do. So 2 weeks from now, we'll send out a doodle and try to find a time for us to meet. Okay?
Can I suggest that you send out the doodle before 2 weeks from now?
Send it out today.
Yeah, send it out and see what people's schedules are.
The doodle will have dates 2 weeks out.
Oh, okay.
Yeah, thank you.
And
And-
Heidi's going to get the governor's conference.
And then location. Do we want to continue to meet in hearing room C? I think it does work well for presentations.
And I think it's more open for the public. I mean, there may be people who want to monitor what we're doing. And as somebody who's usually on that side of the dais,
You want me to put you back over there?
no.
Careful,
But I
hands.
think, I think that, you know, for people who want to come in and see what we're doing, I think that a hearing room is much more accessible than the governor's conference room.
Okay, I'm seeing nods up and down the dais, done. Last but not least, I was remiss in not introducing Christy Martino, who is one of our stars in health services and has agreed to be the project manager for this event and help us staff it. So I wanted to introduce her to the committee before we adjourn. Anything else? Any other business for the good of the order?
I want to say, you did a great job. Very, very good presentation.
Vice Chair? Any other comments? Seeing none, we will adjourn. Thank you so much for your time today. I appreciate it very much.